will be good to see you in between. But you can switch on your videos. So, as mentioned, today we'll be talking about the basic communication skills. So, we know that what kind of patients that you are going to see when you start getting involved with the palliative care team, and what kind of suffering that you're going to see. This needs a lot of communication and listening skills in particular from our side. Then only we'll be able to help the patient in the way that we want. I'll start sharing my presentation. I might stop in between to ask about your points of view. What do you think? So I want this to be an interactive session. I would like to hear from you in between.
Dr. Sreedevi, can I intervene between?
Yeah.
There is some
Yes.
disturbance from your end in voice. So can you put your microphone more close to your mouth instead?
Is it better now?
Yes, ma'am, it is better.
Okay. Okay. So why should we learn communication? So do you think it is important to learn communication skills? Why should we learn all this? Like anyway, many of you are already involved in taking care of patients, or you might have seen patients around your neighborhood or in your family somewhere. And do you think we should learn communication skills? Why should we have a whole session on communication skills? Because we all communicate every day to each other, right? Why should we learn it specifically? Anyone would like to take that question?
You can unmute from your end and speak or give your suggestions in the chat.
Yeah. So anyone would like to unmute and tell me why do you think we should learn communication skills? Because every day we talk to each other, right? In your office, in your family, when you see a patient, in your workplace, anywhere. So why specifically your communication skills? We are all good in communication.
To come across in the right way, because the way you say makes a difference rather than what you say as well.
Yes, very true. Thank you, Manjusha. It's very important how you communicate or what you say, or how you say, as you said. It may not be what you say, but mostly how you say that to a patient. Anyone else would like to share? What do they think? Why communication skill is needed?
Communication skill is something which is mandatory for everybody, I suppose, not only for palliative care.
Yes.
Bulk of the world's problem is only because of lack of communication skills.
Definitely, definitely. I totally agree. Even in our families, this helps a lot when you have a proper communication and listening skills, right? It's very true, not just in palliative care, but in any field that you work or you live. This is very important. So when it comes to palliative care, when you are conveying or communicating well, you are actually conveying that you are ready to listen. You are there to clarify their doubts and apprehensions, because when we deal with patients in palliative care, you know that life has come to a standstill, or there are a lot of uncertainties when they are diagnosed with a life limiting illness. For example, you say incurable cancer, or you say a stroke. Sorry, just give me a moment. Like, you can't be a singer or a dancer, or you can't be a painter, but you can definitely be a good communicator if you learn the skill, especially medical communication. And it allows them to plan ahead. Like if you give good correct answers, like Manjusha was mentioning, what is appropriate or what are the right answers, then it allows them to plan ahead, like what is to be done next. So many a times they will ask, see, I have got an appointment for this particular treatment, I don't know if I should go or not, I don't know whether I should take my wife, or should I take someone else to come with you, should I go to this hospital? So we may not have the right answers, but they may need someone to listen to them and to help them to take some decisions. And It is very helpful in understanding more about the patient. So in palliative care, we talk about the total care. So when you have to give a total care to someone, we should understand the whole part of the suffering that they are going through. Unless we ask, unless we listen to them when they talk, we won't be able to understand what they are going through. Then only after you understand, then you will be able to give palliative care as a total care for them. And this might sometimes give a sense of direction. So when they ask, especially when they talk to doctors or the medical professionals, they'll have a lot of questions like, can I go for work? Will I be able to go back to work? Will I be able to cope up with this illness? So all those uncertainty is there. Am I going to die? Am I going to live? And how am I going to live my life? So all this can be reduced to some extent by proper communication. And it helps to build a long-term clinical relationship. We know that trust is very, very important in any relationship. When you talk about the marriage, everyone says, oh, trust is the most important part of it. Likewise, the the bond that we are going to have with the patient is going to be long-term relationship. It is not like typical hospital setting where you just see a patient for 5 minutes and then you are leaving them. No, in palliative care, we see them for many years, at least months, or sometimes days, but which is very, very crucial. So we have that long-term relationship with the patient. For that, we need to have a good trust among patient and the caregivers like us. And it is very important to take shared decisions about treatment. Like sometimes they'll be very apprehensive. Am I going to be, is the radiation going to burn me? Or is it going to kill me? Is it going to be painful? As volunteers, you may not know the answers, but you can always help them. You can always talk to the doctor in the team and ask, see, this patient has a lot of questions. Can we go and have a conversation and help them to take a decision? So shared decision making about treatment. I don't know whether it was clear from yesterday's session that it is not sometimes that doctors are telling that, okay, this is the treatment. No, in palliative care, we always involve the patient and the family. So suppose a patient is in severe pain and I feel that patient has to come to hospital, but I don't tell them, okay, get admitted. No, that's not the way it works. We ask them, how would you like to have this pain management? Would you like to be at home and take the tablet and see, or would you like to come to hospital, take injections and be with us for a few days and then come back home? See, we always ask them what kind of treatment they want to have. So it's always a shared decision making. So communication becomes very important. Until and unless I open up in a very good way, they won't understand what I'm going to tell or what I'm telling them. And it is more likely to complete the treatment. What do you understand from that? Anyone? Why, how good communication can help, how it can help the patient to complete the treatment? How can it, it's just a communication, right? How it is most likely to complete how, when you communicate well, or how communication skill, how it is going to help the patient to complete the treatment?
Well, if you're able to convince them that it's the right thing for them,
Yeah.
Then they're probably more likely to continue with the treatment or complete the treatment.
Yeah, I totally agree to a part of it, but yeah, sometimes they'll have, we may not need to convince also. Sometimes they just need to tell you that, oh my God, last time I had severe vomiting when I took that injection. Then yeah, they may want to share that experience, and then they may want to uh, uh, I mean ask you, like, can you tell the doctor, is there any other way, any other medication that might help me? And only if you are a good listener, they will tell you, right? Otherwise, they don't talk about it to everyone they see. Only if they feel, okay, this madam or this sir is like, I can tell what I'm going through. So then they will tend to tell you. So
Yeah.
when they tell you, you will find some solution to it, right? We'll try talking to someone. At least, as you said, you counsel the patient. So only if they open up to us, we'll be able to help them. And for that opening up, we need good listening skills, which comes along with the communication skills. So it's highly likely that they undergo or they complete the treatment. Any simple thing, like when we give pain medication, sometimes it may have some gastritis, or some people may have constipation, right? So if they tell me, okay, I have I'm worried about taking this medication, I'm not taking, they just stopped the medication. Like last week I heard from one of the trainees who there, like they stopped the medication without telling us. Then I asked, what did you do then? We told it's very important to take the medication. You cannot stop, it can cause pain if you stop the medication. Then I asked, did you ask them why they stopped the medication? There must be some reason why, right? We all stop medication because there is some reason. Either you are allergic, or you have some discomfort, or you have some unpleasant sensation, or you just feel, okay, I don't need a medication, or it is expensive. Something will be there. So for that, you need to talk to the patient and understand why they are not continuing the treatment. So when you start talking, then they are more likely to take the medication. Now they understand it really well. So it is good for the patient, so that they can continue their treatment. What you said is absolutely right, because we clarify things, we convince them to continue the treatment. And what if we fail to communicate? As I said, they stopped the pain medication because they thought it is, so this patient was bedridden. So they thought, whatever medications you give, I'm not walking, I'm paralyzed, I'm not walking, I've been taking your medications for last 1 month, but still I'm not able to walk. And what we are giving, we are giving something else, we are giving something for his pain. So he thought, anyway, I'm not walking, these medicines are not beneficial, so I'm going to stop it, that's it. So it leads to poor symptom control. So I am unable to relieve his pain. So I have to sit there and make sure that this communicate that this is a medication for controlling your pain. It is not for you to get up and walk. Why should he take it? Is it helping him? Why he is not taking? So everything I have to understand by sit there and start talking to the patient. And same thing, may not comply with the plan of treatment. I give the medication and I'm not even listening why they are not taking the medication. And I'm just telling, okay, you have to take the medication. I've given this, you have to take. They may not take. So there is less compliance. And we tell them, oh, that patient never takes medication. Whatever you give, they don't take. There must be some reason why we do things, right? Always. So just ask why you are not taking. And poor adjustment and conflicts. Then the doctor, oh, the nurse scolded me for not taking medication. Actually, I was having some gastritis when I take this medication. So there arises the conflicts. And when they ask a lot of questions, we feel that, oh, it's a too demanding patient. It very often happens in hospital settings. Like many a times, some of my patients told me that, oh, they ask so many questions. So then I asked them, did you ask these questions to your treating doctor? No, 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 we can't ask these questions. When we ask so many questions, they say, okay, you have so many doubts, Aura. You don't, I don't have time for answering all this. Okay. You just, I know what is good for you. If you're not satisfied with my treatment, you can go ahead with someone else. So these are the responses people generally get. So when they are asking you questions, be patient, listen, and understand what they want to know, how they want to know. So that is also very important. So if we fail to communicate, they ask a lot. When they ask a lot, we tell them, oh, this patient is too demanding. It's a big nuisance for us. So it's very important to communicate properly. And of course, we all know that it can lead to a lot of medico-legal problems, right? A lot of like whatever problem happens between the healthcare professionals and patients is mostly due to poor communication. Either it can be your tone of voice, either it can be what you are telling, or at what time you are telling, inappropriate timing, inappropriate person, or using inappropriate words. So what is communication? It is just counseling, or is it like convincing to do something? Because I know better than you, so I'm convincing you. So is it just convincing, or is it just nice, gentle, soothe talk? What is it? It is not, none of this. Just acknowledge that there is a problem, they have an issue, and understanding the concerns of the patient and the family. So now you have acknowledged that there is a problem. You understood they are going through a tough time in their life, but you have to respond in a most appropriate manner, so that They have more clarity in their situation. So the response to their problem, first understanding their problem and how you respond to their problem is very, very important in communication. It is not just convincing or counseling or soothe nice talk. So these are the 4 core principles in communication. You have to treat a patient with respect. So I remember the first session I heard from Dr. Rajagopal started with the respect. And he was telling, I have so many people sitting in front of me. And you have to start believing there must be one thing that they will be good at than you. There will be one thing in every person that you can, like they'll be good at singing, they have a good handwriting, they'll be good at observing people, they'll be more empathetic, or they are more sensitive. So some one quality will be there, even if it is a patient, illiterate, whoever it is sitting in front of you, there will be one quality that I don't have. Discontinue treatment because lack of trust. Very true, very true. And very often what I have seen in my very limited experience with 10 years with patients, they don't understand what doctors tell. That's a big mistake from our side, because we talk in a language that people don't really understand, because we learned Greek and Latin for 5-6 years. So then we use the same language and people don't understand it. They don't understand. You give 5 medications, 6 medications, once in the morning, then 2 medications you have to take twice, then one is an empty stomach, other is after food. They get confused. Like I get confused if I get more than 3 medications from another doctor. So it's very important to communicate in a language that they understand. And so second point is empathy. So how we differentiate between sympathy and empathy? We are all sensitive when we see patients, right? That's why we are all here to learn palliative care or to volunteer in palliative care. There must be some element of us which, like, we want to help people. So how will we show empathy, not sympathy? How we differentiate between sympathy and empathy? Any responses? It's like, it's very difficult to put in words the difference between both. When you see some suffering, and when yes, Mr. Michael, you are about to tell something.
I think sympathy is kind of giving, empathy is sharing.
Yes, true. That is true. So a sympathy is something that you feel sorry for something. Oh, poor guy, he got this illness, but you are not actually doing something to help them, or you are not actually. So everyone says to think in their shoes, but it's quite ambiguous. It's not clear how to think in their shoes, because we live in a very different situation. Our way of coping is very different, right? I might do something to relieve my stress. You might be doing something else to relieve your stress. So that might be different. Being in someone's shoes is something which is very simple to understand empathy, but you understand that they are going through distress and you're trying to help them. You're trying to do something. You may not be able to solve the complete problem. Like, for example, I may say, if someone is in a road accident, or someone is just had a fall on the road and you are just walking nearby, you can just look at him and say, oh, poor guy, he used to walk every morning. Today, see how he has fallen down. He's unable to get up. I feel so sorry about it. And then you walk away, right? You felt sympathy about the situation, but you didn't do anything. But on the other side, if you are empathetic, at least you will give a hand to get him up. Or if you are unable to do that, you will call at least 4 or 5 people. See, can you help me to take this person up or lift him up or something? So you are actually trying to do something, understanding that this person is in trouble. And as you mentioned, trust is a very important core principle of communication and unconditional positive regard. It is not conversation or convincing someone, okay, this radiotherapy is going to help you. Or this particular Ayurvedic medicine, I know that it is good for cure. Take this herbal medicine. It is very good. So you're convincing them to do something. It is not communication. We are not understanding what they want. We are not even sure whether this herb is going to help them. So it is not about having simple conversation. It is not about convincing or counseling someone. And it is not just nice, gentle, soothing talk. That is not the communication skill that you want to learn. And when I talk about communication skills, it is not about talking. So from now onwards, whenever you listen to this communication skills, it is all about listening. It is not about talking a lot. So there is a study done where they have found out that especially doctors or any medical professionals interrupt patients on every 18 seconds. Every 18 seconds, we have a tendency to ask some question or some interruption. Only that much we can tolerate someone else talking. So it is the main skill that I want you to take from today's session is active listening. Not about convincing or having good, gentle talk, but about active listening. So there are various types of communication. Even if you don't talk, you communicate a lot of things through verbal as well as non-verbal communication. See, in these pictures, they are not talking anything, right? But it is kind of clear what this child is telling. We know that the child is not seeing, like she's not happy. She very clearly expresses that to her face. And the second, the lady, we know that she's not jumping in happiness, right? And the third person is thinking a lot. He's like, he's kind of lost in the thought. So all these things, they are not telling us. So non-verbally, they are communicating. So it is very important. Our gesture is important when you talk to patient. So suppose you are in a very bad mood, but you are having a conversation. Even if you have good conversation, your facial expression, your eye contact, everything will say what you are trying, what mood you are in. Same way from the patient, it is important to understand what they are trying to tell you. When you ask something, how is life going on? How are things with you? How are you coping? Then he looks at the distance, like the third picture. He's looking at a very long distance. Then you understand that there is something more to talk about it, right? Then you have to understand, okay, this person has something more to talk about. Just be quiet and listen. So very important. Our expression is important. Understanding patients and families' expression is also very, very important. So they say that non-verbal communication is the most. Only 7% we communicate verbally. Everything else is non-verbal. Your body language, your facial expression, and the tone of the voice, that exceeds than the verbal communication. So it is both ways. It is about how your body language and facial expression and tone, and it is about interpreting from the body language of the patients and families what they are trying to tell you. They may not tell it actually, right? What if they have some major issue? They may not tell it, but you may have to understand from their body language and facial expression. These are the examples of some positive non-verbal skills. Eye contact, facial expression, how you maintain the eye contact. You are not supposed to stare, but you have to maintain a proper eye contact. The tone of voice makes a lot of difference. How you sit, position yourself, how your body posture is, how much space you give, physical space between you and the patient. And the most important part in a good communication skill, not just in palliative care, but in palliative care, we use that a lot, that is touch. That is a therapeutic touch, not just any touch. It's a therapeutic touch. So they say where to look. It's important to have your eye contact properly. You should not look at the spaces like intimate gaze. You cannot look on the neck and the chest when someone is, we don't do that, right? We don't look at someone's neck and chest when they talk to you. That's an intimate space. You are not supposed to look at there. So it's very important to maintain a proper eye contact. And what is that 80/20 rule? I don't know whether there are any salespeople here. They do learn all these 80/20 rule, because 80% of the time you can look at the face, but you can't stare for long, right? It's very awkward when someone stares at you for a long. So 20% of the time you can take your eye off from somewhere, from the face to somewhere else, but 80% of the time look at this triangle. This is the social triangle where you can keep looking. When you notice sometime, next time when after the session, when you talk to your partners or your family members, just see, we are not actually staring into the eyes. We always look at this triangle. It's not like staring right into the eyes. So make sure that you are having that social gaze, not look here and there, and give break from the eye contact. So it is about not what you said when it comes to tone of voice. It is about how you said it. Many times they say, oh, you take this medication and come next week. And I can change my tone of voice and tell the same thing. Can you take this medication and can we see after a week? Makes a lot of difference. It conveys a lot of empathy. When you just change the same thing, you can tell in different ways. Like all these things are basics that you learn even in your workplace or in your family. But when it comes to patient, when they are going through a life-limiting illness, all these matters a lot. So it is not about what you said, but make sure that your tone of voice was appropriate. And what do you think about these pictures, about the positioning, about how the doctors sit near the patient? Can someone tell me, what do you think about these pictures? Which one looks comfortable for the patient? Anyone?
The upper two pictures, if the patient looks comfortable with the doctor.
Yeah, true.
Top right, top right.
Top right. Top two pictures, someone said, top right. But what very often happens when we go to a patient's home, or when you are visiting someone, or in hospitals, it is always the third position, right? People stand around the bed and talk. But like even when we visit not so close relative who is sick, right? And now you are planning to volunteer in palliative care, you will be going to see some patients at their homes. You don't know the patient, then you don't feel like sitting there, or it might be a dirty place to sit down. So you just stand and it looks so awkward. There we are actually establishing the power ratio. Like I don't want to sit. First thing, I don't have the time to sit. Second thing, you are just bedridden. I just don't want to come near that. We may not mean it. We are just standing because we are comfortable in standing. But what it means when you are lying down and talking, it's not very comfortable, right? Will you feel like, do you think the third picture, the guy is going to open up about his psychosocial issues? Oh, I'm emotionally so upset. He is not going to. But the other two people might, right? Because the doctor is sitting in a way that the positioning is right. They feel close, they feel open. Okay, they might feel like opening up to the doctor. But the third picture, they are definitely not going to tell the doctor that, oh, I had loss of sleep because I was thinking about a lot about my life. I don't know what to do about it. They don't talk such things. So the body positions. So if you want to get, so all these are good techniques to get the most valuable information from the patient and family, the most intimate information. Then only we'll be able to give the so-called total care, or you will just get the superficial information. So the body position is very, very important, where you position yourself, and the posture, slightly leaning forward, slightly bending your body towards the person who are talking. It happens like naturally when you talk to your friend, right? We won't just stand like this and talk. When you are talking to your friend or a family member, we just lean forward and listen to them when they are talking something really important. So the same way, when you see a patient also, the posture is very, very important. Convey that you are there to listen. So these are the active listening skills. When you sit down, the most important part, sitting down. Sit down whenever you go and visit a patient. Make your position like this, the first two pictures. Even sometimes there won't be a chair to sit in a home. Just sit down on the floor. If the patient is lying down on the floor, sit down near that. Or if the patient has a coat, I usually ask them, can I sit here nearby you? So that it's easier to talk. So sitting down conveys that you are there to listen. You have time. You are there to listen. And the posture, leaning forward, will convey that I am here to talk to you. I'm not in a hurry. I'm interested to listen to you. And this is a space concept. When we get a chance to be with the patient, you are actually entering into the intimate space because we are closely interacting with the patient, right? And as a doctor or as a medical professional, I'll be touching also. So you're actually entering into a very intimate space. As volunteers, you might be sitting very close. You might be holding their hands when they are crying. So when you enter into the intimate space, always ask permission. So in our place, we train volunteers to check the BP and the sugar. So all these minor things. So before doing that, we tell them always to ask the patient, just inform. Can I check the BP? Can I just touch? Or can I just change, can help the doctor to put the clothes back? So always ask for permission. When they come to a doctor, it is different. When you go and visit a doctor, there is an implied consent. I don't need to ask every time, can I check, can I touch? Because there is an implied consent for the doctor. But when it's a good practice to ask them, can I just examine? Can I just touch and see what is paining there? Or can I sit here near you? Is it okay to sit here? So it's always good to respect the concept of space because we are entering into a very close personal space. And touch, therapeutic touch. Touch has a great value when you're having a communication. I think it worked like wonders in palliative care because people come up with a lot of emotions that they want to share. They'll share. And you are conveying something sometimes not a really good thing. Like you must be telling them about the incurable part of illness. You might be telling them that they may not be able to walk again. So when they are venting their emotion, touch is a very, very important tool to make just to convey that you are there to care for them. This completely conveys that I care for you. I'm here. You don't need to tell anything. And the touch differs. The first touch is what we call the therapeutic touch. The second touch is more like a paternalistic touch, which is like a teacher telling a student, don't worry, or a father telling the son, it's okay. We don't want that. We want a therapeutic touch, which is usually over the hand. So it has to be appropriate. If a female is sitting in front of you, a male doctor may not be able to touch. There might be some cultural issues also, because in our place we don't do that. So like when we have male doctors, we make sure that there is a female nurse in the team who can just go and keep her hands when the patient is listening to the whole illness. There is someone to just to hold the hand. So touch is a very important thing. And what are the barriers to have an effective communication with the patient and family? Like, although we know everything, there are certain barriers that sometimes we create those barriers, or there are some barriers which we need to be conscious about. Usually patient says lack of time from the doctor. The doctors are always busy. It should not happen when you go as a palliative care team. When you sit down, you're conveying that I have time. And when they go to hospital, imagine how unfamiliar. It's a new place, right? New face, new people, new place, scary smell. Hospital smell itself is something people don't want to talk, right? So there is a lot of lack of privacy. Like in many of the outpatient clinics that we work, it's a very crowded place. You'll have so many patients crowded around you. You don't have that space to talk about your personal things. And many times they don't know whether I can discuss these kind of personal issues with someone. And suppose you are a volunteer, okay? You are going to a patient's house every week. What if I ask a lot of questions? Will he stop coming? I don't want to bother him with a lot of questions. What if they stop coming? Then I don't have anyone else. So they stop asking. These are the barriers that they face. And sometimes they feel that I might cry if I talk. So it's better not to talk. We all do that, right? Some situations we feel like I should not talk because I might cry. I'm on the verge of crying. It's better I don't talk about it. So they don't feel like opening it up. And medical jargon is something that we use very commonly, but from doctors, when you belong to doctors for some months, you will also learn this foreign languages. Then you use, I still remember one lady came and told me, like a patient, she came and told me that I have stage 4 cancer. Okay, then she was quite okay. She looks quite okay, like she was not upset about it. Then I had some doubt. I asked, okay, then what do you understand about stage 4 cancer? What do you understand? What does that mean to you? No clue. She told, I don't know. Doctor told stage 4 cancer. So they just learned, picked up at that word from the doctor. He told there is spread to bones. What does that mean? No meaning. She did not understand anything. She just repeated what the doctor told. So it's very important to talk in the, and very often we say, oh, we tried to talk, but the patient family was illiterate. Literacy is not equal to common sense. They do understand things. It is happening to their body, right? They are going through this. And they don't need a medical knowledge to understand all this. Like, but if they don't understand, that is our problem. We are not using the proper language that they understand. There must be some local terms for swelling, tumor. You just need to learn those and to communicate in the language that they understand. Everyone understands about their own body and their illness. So sometimes the patient will be like quite reserved. They don't talk much. They'll be like shy. How can I tell my non-medical issues to this kind of people? Like, why should I tell about my poverty to them? I don't have anything to eat, but why should I tell that to them? And sometimes people are not able to communicate because they may have huge wound. If they have a oral cancer, they may not be able to talk to you. Or if they have a tube in their throat, they may not be able to talk to us. So that is definitely a barrier. So what will you do then if they are unable to talk to you because they have a tube here? What will you do then? How will you communicate? Any guess? So you went to a home, the patient, like you want to talk to that patient. Now you learned communication skills and you want to practice active listening. Patient has a tube here. Voice is not coming out. What will you do?
Can write or action?
Definitely yes. They can
Facial
write.
expression.
Ma'am, in this type of cases, we can use our non-verbal skills, like
Yes.
you have told us in previous
Excellent.
slide.
Sorry, I lost you in between, but excellent. I mean, all these comments, like first thing, we'll be able to understand from their facial expression. All this non-verbal, how much ever tired they are, they will definitely communicate their distress through their eyes, through their facial expression. They may just hold your hands and they cry. So that way we can understand there is something to be talked. And giving them a pen and paper if they can write, the best thing. So once I've given, lady had a huge oral cancer. She wanted to talk a lot. But then I just give her a paper and a pen from my board. And I told her, what do you want to tell me? Write. Then she wrote the whole page within a minute. She communicated a lot, like about her life. No, I was looking good. I lost a lot of weight. You are seeing the worst part of me now. Will I be able to eat? So everything in that one paper. Next day I went with a notebook because I understood that she wanted to talk. So then I gave a notebook and she was keeping on writing. I think I got at least 3-4 notebooks by the time she died with us, but she kept writing. She started writing everything to her daughter: gas booking number, electricity bill. You have to pay check whether the bill has come before 10th. You should not wear clothes like this. You should not wear clothes properly. So everything she used to write on a book and a pen, with a book and a pen. So it's very important to understand through their non-verbal communication and give, if they can write, they can write, they just give them a pen and paper. And sometimes, as I said, very busy place. Now you went to a home, all the relatives are standing around you, okay, curious what is happening, then how will the patient open up to you, right? There is no privacy. So we can ask them, can I have some conversation with the patient, please, if that is okay. And sometimes we talk across, like suppose the patient is sitting at home, there must be one table and we will be sitting on the other side, and there is a big furniture in between you and the patient, so that may not work. Then they have to talk loud. And during the COVID, I struggled the most with this, because we were wearing all these masks and shields, and then you are maintaining a 6 feet distance. Who will want to talk about their I'm feeling lonely, I'm feeling distressed so loud so that I can hear, right? They will not want to. Then I cannot ask them so loud, how do you feel about your life? I can't just shout it like that. So it's very important. At least now people are getting rid of the social distancing a little bit. So make sure that you are not having any barrier in between you. Make sure that you are in the comfort space, not into the intimate space. Ask permission and then start talking. And phone is one big distraction we all have. In between talking, some call comes and you just take the phone. So always, like, sometimes I have to take the phone because some other nurse will be calling from the hospital asking for some other patient. So I just ask permission, can I just take this call? Because I may not be able to cut the phone. Now I just had to mute and switch off my video because someone came and there is no one at home. So it's good to ask, I'll just come in a minute. That's it. Even to the patients, you can just tell, can I just answer this phone? This is really important. So that's they actually appreciate that a lot. And this is for doctors, but the way we dress and the way we just our facial expression, as though you are coming from a medical unit, they don't open up to us there. So you have to be there for them. You look normal. You don't want to convey that I am someone more powerful than them. And then our attitude, oh, I did think about it, or it's not that important. Like, I came here as a volunteer, you not having that is, I don't think it's important for me, and I don't have the time. So if you don't have all this, it's better not to volunteer for palliative care, because we need time. It is very important. All the things that the patient tell might be very, very important. And this is something we all struggle with, especially as a doctor. I used to struggle with in the beginning. What if they ask difficult questions? They usually ask, when am I going to die? Doctor, am I dying? How much time I have? Am I going to see my child's marriage? I don't have any answer. These are all difficult questions. So better I don't enter into those areas, right? So I ask all the safe questions so that they don't ask these questions to me. What if I don't have answers? They'll ask you also when you start volunteering. Because when you build that rapport, they'll ask you, sir, do you think I'm going to die? Can I be alive at least to see my daughter's marriage? We don't have answers. Right? And then we think, the last thing I told, oh, they are illiterate, they don't understand. Very commonly said. None of them are illiterate, they don't understand. That's our problem. And our lack of training. What if they ask this difficult question? What will I tell the patient? I don't know how long he's going to live. And what if they start crying? Or sometimes they become angry. So this one old man, like a few months back, he came and he was talking about his life. So I just asked, like, who are you? Where are you from? Tell me who are there in the family. Then he started his life story. And at some point, he started becoming angry towards all the doctors in the community. And then he was showing that anger to me also. Oh, I know all the doctors are like this. Then suddenly it just escalated. And we don't know how to handle that. So what I should do, I should not ask those questions. Better to give medications and leave them, right? What if they start crying? The moment you start having good listening skills, not even communication, if you start actively listening, they're going to cry. Because you are giving them, they feel safe. They feel safe with you so that they can express their emotions. Many people, like I still remember, like when I was doing active patient care, many of these people, like retired policeman, like the breadwinner of the family, all all the strong looking males that come. What is bothering you the most? Can you tell me about it? The moment you ask that question, done. They start crying because no one has asked them that question till then. That one particular question is very, very important. And we feel insecure. What if they start crying? I don't know. What if they start crying in an outpatient clinic? So this is how we have to get practice. We have to deal with this crying, the anger, maybe the happiness, the gratitude, everything we have to deal with. And what we do to avoid all this situation, I just keep myself so busy so that no one is going to ask me any question. I'm just busy with my phone, or I keep writing my file, or you keep looking at somewhere so that they don't ask most of the question. Again, you are conveying non-verbally that I am not interested. And we sometimes categorize these patients. Oh, she's a difficult patient. The bed number 4 patient or the CA patient. We just label them just because they are patients. They don't become bed number 4 or breast cancer when they are getting diagnosed. They are still people. They still have a name. You can call them brother, bhaiya, bhai, uncle, auntie, anything which is culturally okay for them or in your place. And what we do, we pay attention to safer aspects. I am good in pain management. I ask questions only about pain. That should not happen. We should take those challenging questions. We should let them vent out their emotions, whether it is anger, whether it is crying, whether it is guilt, whatever it is. Be an active listener. So these are some of the examples. And these are questions that we don't ask so that they don't come up with a problem. How are you feeling today? How have you been coping? How are you going through all this? Tell me. Who helps you? What is the support system? So all these questions you ask, they are going to open up. So to avoid that, we stop asking these questions because we don't know how to handle it. That's the distancing technique. I'm telling this because we should not do it. We should not try all this distancing technique. Distancing technique is something that we use to distance people so that they don't ask difficult questions to us. And sometimes we ask leading questions. These are all the don'ts in communication. You should not ask the leading question. Your pain is better, isn't it? Definitely he's going to say yes. I'm leading my question to get a proper answer for me. Or sometimes I ask closed question. Do you have pain now? Either it is yes or no. I should ideally ask, tell me about your pain. Then he'll tell, oh, my pain started here. I was sleepless, then it increased, then I took this medicine. I'll get the whole story then. So always ask open question. Please tell me more about your pain. He can't say yes, he can't say no. He has to tell about his pain. Please tell me more about your family. It's not a one-word question that you are asking. You will get whole story with that one open-ended question. So how to communicate effectively? It's very important to start the conversation with an open-ended question. Always start with an open-ended question or something. Today I'm going to deal with the pain part of it. Okay, so I'll ask, please tell me more about your pain. How is your, I won't start with how is your pain. It's better. That stops there. I'm fine. That's it. And be empathetic. So how will you convey that you are empathetic? You have to convey, right? You are empathetic, but you want the patient to understand you are empathetic, right? So we have to say what you see. I see you are in a lot of distress. I see you are in pain. Never use the word, I understand you are in pain. One patient actually asked me, how do you understand? Have you had this cancer before? Are you in the same family as mine? You never understand what I'm going through. So some people don't like that I understand. So it's instead, you can tell that I see you are in severe pain. Let me help you. Let me see how can I help you. And always have a balance between hope and truth. You cannot lie. someone says, okay, the typical example is, I'm done with this life. I think I'm going to die. It's better that I die. What is the typical answer we give? Don't say like that. Don't worry, everything will be all right. Is everything going to be all right for palliative care patients? Like everything will be back to normal? Very often, no. So there should be a balance between hope and the truth. But I can't say, no, everything is not going to be all right. I can't say that also, right? There should be a balance between hope and truth. I have to give a realistic information. Can you just excuse me for 1 second? So always there should be a balance between hope and the truth. You can't say the truth, right? Like, oh, this is not going to heal. But I can't say, so this lady who used to write a lot, so she had a huge wound on her face because of her progressive oral cancer. And she came to us thinking that she will get healed. She had that hope that with all these medications, I'm going to heal the wound and she's going to back to normal, which is not the truth. The wound is large. She will definitely have a disaster from the wound, and it is not going to heal at all. But I should not tell that, okay, your wound is not going to heal. That is not the way to tell it. But I have to make sure that she understands that it is an unhealing or non-healing wound. So that is a part where medical professionals do. But as a volunteer, you should not use like, don't worry, it is all right, everything should be fine, or I can understand these kind of things. And we have to avoid unhealthy curiosity. Like sometimes they might have had tobacco chewing in their past, and the patient is going to die. If I ask the question, oh, you used to chew tobacco for 20 years. How many cigarettes you used to smoke a day? The patient is dying. The question is relevant if I'm going to diagnose. Suppose the patient is coming for the first time, oh, there is something inside my mouth, that question is relevant. So suppose when you are going to visit a patient, he has an end-stage lung cancer. We know that he is a smoker. Oh, he used to smoke cigarettes. Is that going to change our plan of treatment? Are you going to reverse it? No. So all this unhealthy curiosity, just to understand what caused this, that should be avoided if that is not going to help any of the, that is not going to change any of our treatment plans. And sometimes they may share the very intimate things from their life, right? When you are a good listener, and if you develop a good trust between you and the patient and the family, they may share information which is really confidential. Some of the information you may have to tell the team. For example, someone is telling you that I'm planning to suicide. I've kept everything ready, but don't tell this to the team. I trust you a lot. Promise me you don't tell. But that you can't hide. You can't give confidentiality there, because that is going to end someone's life. That you have to inform the medical team, right? But otherwise, if suppose they are telling you very intimate information, which is nothing, like telling the team doesn't make any difference sometimes. So I had a patient who was HIV positive. So this lady came and started talking about her past life, and she shared all the intimate information. That doesn't, like, I don't want to tell that to my team, right? However she got the HIV doesn't matter. How am I going to help? How am I going? My team is going to help is what that matters. How she got it is not relevant there. I just don't want to have unhealthy curiosity also. Second thing, I have to maintain the confidentiality. And it is very, very, the most important part in communication is closing the consultation. So you told so many things. The patient is telling you, sir, I don't have, I just need this, I have this problem. So then you told, okay, let's do one thing. I will talk to the doctor and get back to you. I'll ask the doctor what to do, when are they coming, and get back to you. So you might have had a lot of conversation in last half an hour or something. It's very important to summarize. They might have understood only half of it. We think that you communicated really well, right? We are happy. Okay, I had a good conversation. I told everything to the patient. They might have understood only half of it. So it's very important to tell them, can you tell me what agreement we are in? What are you understood? So that's the best way to understand whether there is a gap in communication. Sometimes the patients may not want to talk and summarize. Then it is a good practice to summarize. Okay, so we have talked about getting a wheelchair for you. We talked about talking to the doctor about your pain medication. Then we think about supporting your children's education. So these are the three things that we talked about today or discussed. So you close the conversation effectively. Now they are clear. Okay, these three things they have promised. And when you promise these things, we have to make sure that we are able to do it. So I'll just stop my sharing here. We'll just see a video on two scenarios, the same scenarios, and we'll just have a discussion based on that. Raju, you're there?
Yes, ma'am. Can you stop the share?
Or I have pain. We usually ask, why didn't you take medications? There are a lot of medications here. Why didn't you take that? So can someone tell me what all things you noticed which could have been better? What should I have done better? So this is not a doctor visiting a patient. This is an ASHA worker.
Ma'am, actually, on the first, like, I'm too busy, it should not be told. And the lady should sit on a chair and talk to the patient and make the patient comfortable to have a talk to her.
Yes. Yes. From the
About
beginning itself. Yes.
about the medication and everything.
Yes. The first thing is to sit down and convey that I have time, and not like in a busy. If you don't have time, better not to visit the patient, right? If you're too busy, it's better to avoid that consultation at that point in time. Anything else that you would like to change the way she did? And it was not too
yes,
harsh
ma'am.
also. She was not shouting at the patient or anything. Everything was subtle, but there was some issue, right? Yes, Saurav, please.
Yes, ma'am. She's one more thing. She's not trying to listen the patient.
Yes.
Yeah. She should listen the patient. Many times, patient is experiencing, like as you said in the previous slide. He might be he is having some other issues like psychological issues other than his physical problem. She should listen to the patient. In this video, she is not supposed to uh, do like this.
Very correct. Thank you, Saurabh. So there is no active listening. There is
Ma'am,
always interruption.
one,
Yes, Fancy.
one,
Please.
one, ma'am, she has to touch the patient and listen the proper what he want to tell, and she is not listening properly to the patient, na?
Yes, very true. Sometimes touch might work, but she has not even sit down. So I don't know how she's okay in touching the patient, right? Anyone else? Thank you, Pansy, for that feedback. Anyone else would like to comment on any other aspect?
Ma'am, in palliative care, we also take care of the family. Like
Yes.
in this situation, like the lady was blaming the family member that you are not giving him anything to eat in front of the patient, and that was something.
Yes, I totally agree. Maybe the wife might have tried a lot to feed. He didn't want to eat, and she might be distressed, right? Many a times the wife must be distressed that my husband has not eaten anything properly. And you are going there and telling, why can't you just cook something for him? Why can't you just force him to eat? That adds on to the guilt to the wife. Oh my God, I have been trying a lot. See, this person has come and asked the same thing, right? Very, very good point. It's always about the patient as well as the family, not just the patient. Anyone else?
Ma'am, she shouldn't have blamed the patient because he was suffering the situation because he was an active smoker. She shouldn't have done that because that only will make the patient into a deep sorrow condition.
Yeah, yes, very true. Like we said, unnecessary curiosity or guilt. That is not relevant there. Why, like, why did you want to tell at that point of time, right? We all know that smoking has caused the cancer, but we don't, it's better not to bring it up there, because already the patients will feel generally guilty. Oh, if I had not smoked, I would have rescued my family. And you're adding on to that guilt. Oh, if you have not smoked, it's better. You could have, you didn't have to go through all this. Very, very good point, Adira, right? Thank you. Any other point? This patient told, I'm unable to sleep at night. Right? And what did I tell them? Oh, I'm also unable to sleep because it's too hot. Right? You are comparing that, or you are just making it insignificant because it's too hot, a lot of mosquitoes. I'm also unable to sleep. So that's not the way. Like sometimes they are, these are cues that they are giving us. They're giving a cue that I want to talk about it. That's why he is trying to communicate a lot of things, but the ASHA worker is using a lot of distancing techniques. Just coming back to the safer aspect. Okay, I'll tell the doctor and get back to you with some medications. That's a safe thing, right? She doesn't have to deal with any of the emotions there. And there is a facial expression of sympathy always. Oh, that's so bad. That facial expression is there, conveying that that she's like very sympathetic, not empathetic. And the distraction, phone, and telling over the phone that I'm with a patient. You may not want to tell that, right? That I'm near a patient. Yes, should she ask him what would he like to eat or what does he crave for? Definitely yes. Would you like to eat something? You feel like eating something? Or sometimes they say, I don't want to eat anything. That very often that is the case. Then ideally we should explore more. Is there any reason? Why do you not want to eat? This person told, I have nausea, I feel like vomiting. So might be simple vomiting, might be depression. I don't want to eat. I want to die without eating. That can be anything. So so it's always good to ask the question again, like, is there any reason why you don't want to eat? So all these questions would have been asked. I'll just show another part of it, like how she should have done it in a better way. That's not the ideal. I'm not telling that it is a perfect way to communicate or is it the only way to communicate, but just an example so that you can just differentiate between the both. It's the ideal video, but that is something that you can do. The tone changed, right? The patient started telling why he's not sleeping. I'm worried about my family. I just don't feel like eating. So once you start listening, sit down there and convey that you care, they may come up with their actual problems, then they tend to open up a lot. I'll just summarize my presentation. There are a few points that I saw the questions in the chat also. I'll just take them up quickly before we end today's session. So these are the steps towards effective communication. It's always good to build a proper relationship with the patient so that by not conveying the sympathy, but be empathetic towards them. Like, I see you are going through a lot. We don't understand. I never use the word I understand. So I see that you are going through a lot. Acknowledge. So it's about acknowledging their pain, their loss, their distress, and open the discussion sensitively. Understand that they are going through a lot and provide active listening. Active listening, how? How will you convey that you are actively listening, not just listening? It is by nodding your head, just when you listen, you just give that, right? So by conveying, by doing that, they will understand that you are listening. And in between, you can ask questions like, oh, can you tell me more about it? So then they understand you have already listened to what they have been telling. And when you listen, we have to listen what is said and what is not said from the body language. Someone earlier expressed that when they're unable to communicate, we have to listen what is not said from their body language as well as from their expression. Gather as much as information as possible. What do they know? What do you think might be the problem? What worries you the most? And this must be a tremendous shock for you. These are examples so that they'll tend to open up a lot. And we will understand what exactly the patient and family knows about the illness than assuming. Understand their perspective. And it's like, it should be, we are there for their agenda. We are not there to convince to do something. The ASHA worker should not go there to convince him to take medications. She's going there to understand how he's doing and why he's not having enough pain relief. Then explore more. Can you show me the medication? Oh, why are you? She's not blaming there. She's just asking why he's not taking it at the regular time. Is there any reason behind it? So it's very important to go behind, understand the patient's perspective of not taking medication, and be prepared for silence, awkward silence. They may just stop talking. There might be anger, they might be crying. So yeah, there is a question in the chat. I'll come back to that. What if they start crying or we get emotionally invested? And we need to facilitate. Sometimes they stop, there will be a long silence and you waited for some time, few minutes, again silence, then maybe you can just facilitate it. I can see how upsetting this is for you. Then they might start again. They might have got lost in their emotion. So it's just to facilitate to the next level. You can just say all this, like, I can see that you're suffering a lot. Then they come up with the next part of it. And share the information, understand what they want to know. Then only talk to them. Like if they don't want to know anything about their illness, just don't talk about it. And use the language that they can understand. And just don't close the interview. Like she told, okay, I'll talk to the doctor about your medications and I'll come back tomorrow so that we can have a conversation more about your concerns. There is a promise that she will come tomorrow. If I'm promising, I have to go tomorrow. Otherwise, I should not promise. Or I can say that I'll give you a call by noon and see whether I can come tomorrow. So there should be a proper closing. It should not abruptly stop the interview. Like agreement on problems and plans. Today, they might want to be cared at home. Tomorrow, they are telling, no, I want to be at hospital. Then we should not say, oh, yesterday you told you want to be at home. Today you're telling going to hospital. How can you just keep changing your decision? It will change. They're going through a lifelong suffering, right? Today they might be comfortable being at home. Tonight I became so anxious. I just want to be with the medical team so that I feel comfortable. So this is not an ironclad contract. You can always keep reviewing depending on their needs. And always have a proper closure. Just don't stop abruptly. And understand whether they have understood what you are telling. Just summarize back to them or tell them to summarize. And leave the door open to talk again. This lady is telling in the end, please call me if there is any doubt. And if I'm telling that I have to pick up the call, I have to call them back. You can just tell and just don't take the call. So we can, and she's telling, I'll come back tomorrow so that we can talk more about your family tomorrow. Is that okay? Because she doesn't have time today. But she's not telling, oh, I don't have much time today, right? Very sensitively, she told, okay, is that okay if I come tomorrow and have a conversation again about it? So that by that time you will get good pain relief also. So I'm just ending up with this. The most important practice or the most important thing that we have to learn in communication skill is not to keep talking. It is always about active listening to what they say, listening to what you see, which they may not even tell you. And it is not passive listening. You can just simply sit and listen and you can tell I was listening to the patient. No, that will not work. It has to be active listening. You have to nod your head. You have to ask questions in between without interrupting, or you have to just make them understand that you are listening. And always use open-ended question. Let them talk. Do not give the opportunity to end the conversation with a yes or no answer. Always ask open-ended question. I'll just stop sharing because I wanted to take questions and some discussions. So I think, yeah, the first question was about, yeah, answer to the difficult questions that I asked, like what if the patient starts crying? What will I do if the patient starts crying in front of me? I don't do anything. The best thing is not to do anything. I'll just touch their hand. I'll just sit there, complete silence, nothing. So it's like a completely filled cavity, like a water filled tank. It just wants to come out. There is no place to let it out. They're just letting it out. Just be patient. The problem happens when we try to fix things. Oh, don't worry, don't cry, it is going to be okay, we are all there for you, we are here as a team, we are there to help you. You don't need to fix those things at the right then and there. We know that we are going to be there for the patient, right? We are sure about it. Just be there. Let them vent their emotion. Let them cry. Let them I just keep my hand over their hands. If that is appropriate, if I'm just sitting near to them, I just keep silent. Then I ask after a long silence, if it is going long, then I'll tell, do you like to tell more about it? Sometimes they say no, maybe sometime later. But it's okay. So when are we going to see next? They may say, I'll come next week, doctor. We'll talk then. That's fine. Just don't do anything. Let them vent their emotions. What if I cry? That's the another question I think that you wanted to ask. Like, what if we become emotional? Absolutely fine. Yeah, I'm not going to cry with every patient. There are moments where I feel like crying because they might have gone through a lot. There are instances, at least one or two, in last 10 years, tears have rolled down my eyes. Absolutely fine. You're also human beings. I've seen people appreciating it happened out of a lot of distress. The patient was going through a lot of distress and she was dying. She was of my age. She had children of my age. I literally got carried away. She just hugged me and started crying. Then I also started crying. That's fine. She felt relieved actually after that. She felt relieved that she didn't tell, but she understood that I understand this. I can at least relate that to what she's going through. And it is okay. I'm sure you are not going to cry with every patient. That is not going to happen. At least once in a while, you might feel like crying with them. That is fine. They don't feel any. That's nothing wrong about it. And anger. Sometimes patients become so angry. Why didn't you tell that earlier? I didn't know that. You have not written it properly. They might be angry. They might not be angry towards you. There must be a lot of things happening in their life. Don't take it personally. Just be there. Don't try to calm them down. Don't try to tell them, oh, sit down, we'll talk about it. No. Just stand still. Listen to them. It will keep, like, they're not going to be angry for half an hour or so. It will keep, once they understand that you are not resisting it, you are not trying to calm them down, they themselves will come down. They'll just, the intensity of anger will come down gradually. Once you feel that they are back to their normal self, then you can tell them, can we just sit down and talk about it a little bit more about it? Let's see how it happened. Let's see how can we go about it. So not when they are in anger mode, you can't tell all this. Just wait there. Just listen. Don't try to control or calm them. Just be there. Then there is a point where they calm down and then you can start your conversation. Okay. Yeah, so there is Saurav Singh is asking, like, when they have loss of appetite, we tell them small frequent meals. What can we do other than this? I think I will ask the patient first why they don't want to eat, because many terminal cancers, they won't feel the appetite. When they are dying, they don't need food. The body don't need any energy or fuel. So it's absolutely normal to have loss of appetite. So when you, like, giving food is kind of expression of love. When we love someone, we feed them, right? When you have a loved one in your home, you feed them. Or when your kid is sick, you feed them. Everything is through food. We communicate everything through food. Food is such an emotional binding agent between relationships, right? So when you cannot feed someone, it's a great distress. So first thing is to understand why this person is not eating. If they are going like a terminal stage or dying, I would not recommend to feed also. If they don't want, that is fine. But suppose the patient is having oral ulcers in the oral cavity and he's unable to eat, I definitely have to treat it, right? He's unable to eat because he have a lot of ulcers in the oral cavity. He's not going to die. So I should ask why you are not eating. It must be pain in the mouth. I should start medication. If it is just that he's in the terminal stage, I'll just say, just give 1 spoon. If it is he's telling to stop, stop it. But repeat that spoon after 1 hour, just small frequent meals. That is what I generally recommend, but that purely depends on the patient's illness trajectory, where they are. Are they going to die, or are they someone who needs feeding? Yeah, so how do we handle the trauma that we see, and how do we accept and let it not? That's a very, very important question. The self-care becomes really, really important when you come to palliative care, because you are dealing with the suffering and you can't take it back home. You can't just take all this suffering back home and then you are totally lost. You have a family to take care of, and you are doing this 365 days for years, right? So it is not about, like, we need to empathize, like I said, thinking on their shoes, but you have to remove that shoes when you are going back home. You can't wear the same shoes to your home. But there are some instances where we get literally, like, some traumatic deaths happen. As I said, the lady was of my same age. She had the kids of my kids' age. And I was imagining, like, what if this is happening to me? Who is going to take care of my kids? She's in terrible pain and she could not see her kids before she died. I was thinking, putting myself there, what if I am unable to see my kids? How am I going to react? So these are once in a while situations that just really hit us. So what we do is, like, when I am emotionally upset, my nurse will come and talk to me. I make sure that I talk to my team. Like, at the same day, many of the team members were upset because all of us were like of her age. It was really, really traumatic to the team. So what we did is, like, we did a debriefing. Okay, once the patient had, when she was out of this distress, we all sat together and we discussed. We just vented out the emotion. Like, we still follow that in the team meetings. Everyone shares their, like, very experience, so that we just let it out. It is okay to cry. I remember I cried, my nurse cried. We both were crying. When we're debriefing, that is okay. Just letting it out. And then we focused on how we managed it. What are the good things we did for him? She was pain-free. We could do 1, 2, 3, 4, 5 things. If she was not with us, she would have died in agonizing pain. So we focused more on what, as a nurse, I told, see, as a nurse, you did such a great thing. You took care of her really, really well. So it's always a teamwork. Talk to your colleagues, talk to your friends in the team. Have a debriefing when you have such traumatic incidents. That's very, very important. And just have your own ways of self-care. It must be taking a break once in a month. Just go away from everything for 2 days and come back and start dealing with the thing again. I've been working in this for, like, it's a very small experience compared to many other, but 10 years. I always felt like going back next morning. It has never kept me back at home. I always felt like I could relieve that. Oh, if I were not there, she would have died in pain. I wanted to do that for more people. I made them cry. So these people tease me, my team members. So we make everyone cry. That's fine. I gave them an opportunity to cry. Next day, I want to give that opportunity. I feel privileged to be a part of this, because they are sharing the most intimate emotions and everything with you. And you are there to listen. There is no one else to listen. But as you said, it is very important to have that line. Like, you can't just take back through that your personal life. You can't just get carried away. Yes, sir, please.
Do you share what you go through at home? Does it upset people at home?
Yes. Some people, yes. When I talk to my mom, she is like, no. You better don't work in this situation. Why do you want to work with such a depressing situation? Why can't you just do something else? So I don't talk to them about it. But there are people who appreciate that. Oh, who are there to tell me that you did a wonderful thing. It is okay, you cried. It is okay, you feel weak. You take a break for 2 days. But you did something really wonderful, which I was unable to do. I didn't have the privilege to be with such patients. So that is okay. So I share to them, not to people who just don't want to listen to all the suffering. But I definitely, not that every confidential part I may not share, but I usually share what I went through when I saw that I couldn't I couldn't get back to myself for some time. It will take a few days sometimes to recover. But I talk to my colleagues very often. I talk to my colleagues, like we have a multidisciplinary team meetings. I tend to talk to my friends who are doctors, to nurses, and I say I just totally lost it. And then they are there to listen. They talk back to us also, madam, this was terrible. So we have that meeting and just debrief about it. I know that that might not be like, when you listen, you may not be able to practice it. And as I said, these are the skills that you need to practice. You can't just listen and then go back and start, like you will learn everything from the session, not going to happen. It's about seeing one patient, the need will be different. The next patient, the reaction will be different. The need will be different. So it's all about practicing, keeping all this in mind. And it evolves wonderfully over years. Even if you are not a good communicator now, when you start seeing patient, it evolves beautifully over a period of years. You will learn how to deal about yourself as well as for the patient. And I just wanted to mention, teamwork is really important. You can't just do it alone. You need to have a team. You need to have someone with you. Are there any other questions? I hope I took everything in the chat.
Yes, ma'am. In the chat, you have completed everything. Any questions? We are running out of time too. So